Hello everyone, here is the class on neurocognitive disorders. The objectives are divided in different parts. So the first session, the objectives are to compare and contrast the clinical picture of delirium with that of dementia, discuss 3 critical needs of a person with delirium, identify 3 outcomes for a patient with delirium, and summarize essential nursing interventions for a patient with delirium. In this chapter, we are discussing on various disorders that affect our cognition and our memory, which results in a significant change in their level of functioning. So the neurocognitive disorders are majorly divided into 3 main aspects. First is as delirium, secondly mild neurocognitive disorder, and third as major neurocognitive disorder. So the first one is delirium. So delirium is characterized by disturbance of consciousness and a change in cognition that develop rapidly over a short period of time. So there is definite impairment in attention. There is disturbance in cognition, and these disturbances develop over a short period of time, usually hours to few days. Delirium is a common complication of hospitalization. About 22% of general medical patients and up to 80% of intensive care patients and between 11 to 35% of surgical patients could have delirium. And the factors that lead to delirium are there are many factors that lead to delirium. Few risk factors of delirium include cognitive impairment, older age, severity of disease, presence of infection, multiple comorbidities, polypharmacy, intensive care units, unaddressed orientation, visual or hearing issues, fractures, surgery, stroke, aphasia, vision impairment, any restraint use, change in hospital rooms can lead to delirium. So looking into the clinical picture of delirium, it is an acute cognitive disturbance and is often reversible. There is a disturbance in attention. It has an abrupt onset with periods of lucidity. There is disorganized thinking, poor executive functioning, disorientation, anxiety, agitation, poor recall, and sometimes there can be delusions and hallucinations. Usually visual hallucinations follow delirium. Let's look into the application of nursing process. First is assessments. So we have to look at 4 cardinal features of delirium. First is it has an acute onset and a fluctuating course. Secondly, it has a reduced ability to direct, focus, shift, and sustain attention. Third, patient will have a disorganized thinking. And fourth, there is definite disturbances of consciousness. Patient may have difficulty with orientation, first to time, then to place, and last to person. For example, a man with delirium may think that the year is 1972 and that the hospital is home and the nurse is his wife. Orientation to person is usually intact. And one aspect is disorientation, confusion is usually worse at night and during the early morning. During the day, patients may be lucid. Delirium patients can have cognitive and perceptual disturbances. Illusions and hallucinations are common in case of patients with delirium. Patient may perceive a stimulus as something different, like misinterpret the stimulus. That is called illusion. For example, a cord in the blind can be misinterpreted as a snake, And for hallucinations, visual hallucinations are common, and rather than auditory hallucinations. So the visual hallucinations may be in the form of maybe someone standing behind me, or seeing a giant spider crawling, and even sometimes patient can have tactile hallucinations. Patient may feel that there are bugs crawling on their skin. And next aspect is physical needs. The patients in delirium may be so disoriented that they will not take care of their nutrition, sleep, or rest, or even their self-care. So elimination needs. So all these aspects need to be taken care by a nurse. And the patient may also have the patient's level of consciousness may change from lethargy to stupor, or from semi-coma to hypervigilance. So in hypervigilance, the patients are very alert, and their eyes constantly scan the room, and they may have difficulty falling asleep, and disoriented or agitated throughout the night. So usually it's said that delirious patients may have more difficulty during the night, and usually during the day they are more lucid. So we need to be aware of these changes and fluctuations in their mood and in their activities. Next, going on to mood and physical behaviors, as we said, their behaviors may be fluctuating from night to day, and so the behaviors might change dramatically within the short period. Patient can have agitation. So if the patient is agitated, the delirium is considered hyperactive. And if there is no agitation, delirium is considered hypoactive, and the mood may swing from fear, anger, anxiety, sometimes to depression or apathy. And finally, we need to have a self-assessment, which will help to prevent countertransference towards the patient. So what are some nursing diagnoses that you can think of? So first one is risk for injury. Next is acute confusion, risk for deficient fluid volume, disturbed sleep pattern, impaired verbal communication, fear, self-care deficit, and impaired interactions. So our outcome criteria for the patient would be the patient will remain safe and free from injury. And during the periods of clarity, patient will be oriented to time, place, and person. And patient will remain free from falls and injury while confused, with the aid of nursing safety measures. And as for planning, we need to ensure necessary aids and supportive home team. And there should be visual cues in the environment, for example, a big clock or a calendar in the patient's environment for reorienting for the time. And there should be a continuity of care providers, as the patient would have better outcome with the same staff, rather than having a multiple staffs taking care of the patient within a short time period. So what are some nursing interventions that you can think for this patient? First is to identify the cause of a delirium and initiate therapies to reduce or eliminate these cause or factors causing the delirium. Monitor the neurological status on an ongoing basis. Administer PRN medication for anxiety and agitation with caution. Assist with needs related to nutrition, elimination, hydration, and personal hygiene. Minimize the use of physical restraints. Acknowledge the patient's fears and feelings. Provide patient with information about what's going to happen and what can be expected. and inform or reorient the patient to person, place, and time as needed, and always approach the patient slowly and from the front and address patient by name. Always introduce self to patient when approaching the patient. Communicate with simple, direct, and descriptive statements. Maintain a well-lit and hazard-free environment. Place an identification bracelet on a patient so that even the patient, there's a high chance for wandering, so we need to be safe. We need to be aware of safety for this patient. And use environmental cues such as signs, pictures, clocks, or calendars, and color coding of environment to stimulate memory and for reorientation. Provide a low stimulation environment and encourage use of aids that increase sensory input, for example, eyeglasses, hearing aids, and dentures. So encourage the use of aids to get that sensory input for this patient. For evaluation, a long-term outcome will be patient will remain safe and patient will be oriented to time, place, and person by discharge. The underlying cause will be treated and ameliorated. Next, we'll look into mild and major neurocognitive disorders. So a broad term that is used for this is a dementia, which includes a deterioration of the cognitive functioning, and there is an impairment of intellect in these patients. The objectives of the chapter is recognize the clinical picture of mild and major neurocognitive disorders, give an example of the following symptoms, assess during the progression of major neurocognitive disorder, amnesia, apraxia, agnosia, and aphasia. So the major criterions are the progressive deterioration of cognitive functioning and global impairment of intellect. That's the term as dementia. There is no change in consciousness. In case of delirium, we saw there is alteration in consciousness, but in major or minor neurocognitive disorders, there is no change in consciousness. There is difficulty with memory, problem solving, and complex attention. So in mild neurocognitive disorder, it does not interfere with activities of daily living and does not necessarily progress. So whereas in a major neurocognitive disorder, it has interfered with the daily functioning and independence of the patient. So once it has not affected his ADL, it is considered mild, and once it started affecting his daily functioning, the cognitive disorder is considered as a major neurocognitive disorder. So some causes for major neurocognitive disorders include Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies, vascular dementia, traumatic brain injury, substance-induced dementia, HIV infection, prion disease. Prion is a virus, Parkinson's disease, and Huntington's disease. So all these illnesses can cause dementia, and usually that is considered as a major neurocognitive disorder because there is a marked impairment in their functioning and intellect with these infections or structural brain changes. One of the most frequently occurring major neurocognitive disorder is Alzheimer's disease. Even though this disease can be seen at an earlier age, which is called an early onset Alzheimer's disease, it is usually seen at age 65 or older, which is known as late onset Alzheimer's disease. As per Alzheimer's Association 2014, there are about 5.3 million Americans with Alzheimer's disease. And 2/3 of people with dementia are women. Even though it affects both men and women equally, this statistics is because women tend to live longer. Studies shows that it affects both men and women equally. Looking at the etiology of Alzheimer's disease, the major contributing factor is the biological factor. So first is neuronal degeneration. So studies show that there are two major changes that's happening. So first is accumulation of protein beta amyloid outside the neurons. So these amyloid plaques outside the neurons interfere with the synaptic connections. And secondly, there is accumulation of protein tau inside the neurons, which leads to the neuronal death. It blocks the flow of nutrients, which lead to neuronal death. So these are the possible causes behind the pathology of Alzheimer's disease. And it said that these neuronal degeneration starts at hippocampus, which interferes with recent memory, and then it affects the cerebral cortex, which is responsible for problem solving and higher order cognitive functioning. Another factor, biological factor responsible is genetics. It says that one of the gene called apolipoprotein E is responsible for Alzheimer's. A specific allele of this gene, it's called epsilon 4 allele, is at increased risk of Alzheimer's disease. Next is other risk factors are age and family history. It says that patient with higher age, which is usually after the age of 65, but even though there are some cases less than 30, but age of greater than 65 is seen as a higher risk, and if there's an immediate family member with Alzheimer's disease or dementia, patient can have a higher chance of having a dementia or Alzheimer's disease. Next is cardiovascular disease. Some evidence states that people with cardiovascular disease are at increased risk of Alzheimer's disease. And some lifestyle factors such as inactivity, high cholesterol, diabetes, and obesity are found to be risk factors of Alzheimer's disease. Next was head injury and traumatic brain injury. It said that brain injury and trauma are associated with increased risk of developing Alzheimer's disease. People who suffered repeated head trauma, such as boxers and football players, may be at increased risk of Alzheimer's disease. Another environmental factors which is responsible for Alzheimer's is said to be social engagement and diet. There's some evidence that these factors may be responsible for the development of Alzheimer's. So a person needs to be mentally and socially active and consume healthy diet to prevent Alzheimer's. Looking into the clinical picture of Alzheimer's disease, of all dementias, about 60 to 80% of them are Alzheimer's disease. It is important to distinguish normal forgetfulness and memory deficits in dementia. Severe memory loss is not a normal part of growing older. Slight forgetfulness is a common phenomenon of aging process, but not memory loss that interferes with one's activities of daily living. And in dementia, in major clause, we have to identify that this memory loss interferes with activities of daily living. So the Alzheimer's disease may progress from mild to moderate to severe. In your textbook, table number 23 outlines these stages of Alzheimer's disease and the hallmark features of this Alzheimer's disease. So Coming into application of nursing process, we need to be doing a proper assessment, and we should be aware that patient would utilize defense mechanism to cope with the memory loss, as it is very progressive. It is not a sudden onset of memory loss, so the patient will slowly there will be a slow decline in their memory. So the patient would try to compensate for the loss of their memory. So it is very difficult to identify a dementia early stage of the disease. Next, another defense mechanism seen is a confabulation, that is creation of stories in place of missing memories to maintain self-esteem. For example, there's a beautiful example that is given in your textbook. That is, a nurse addresses a patient who has remained in a hospital bed all weekend. So the nurse says, "Good morning, how was your weekend?" And the patient says, "Wonderful, I discussed politics with the president and he took me out to dinner." So it is not the same as lying, because when people are lying, they are aware of making up an answer, but its confabulation is an unconscious effort by the patient. So it is creation of stories in place of missing memories. Next is perseveration, that is persistent repetition of a word or phrase or gesture. Even though we ask one question, the patient will continue to say that answer even though we moved on to the next question. So for example, you may ask the patient where she was born, and her response is Akron. You ask subsequently, you ask the patient to spell another word backwards, and her response is again Akron. So it is kind of repetition of phrases or behaviors. Next is avoidance of questions. Sometimes the patient will completely avoid the questions. And so certain things we have to look in these patients is agraphia. Agraphia is diminished ability and eventual inability to read or write. Next is aphasia, that is a loss of language ability. Next is apraxia, that is loss of purposeful movement in the absence of motor or sensory impairment. For example, apraxia of dressing, the person is unable to put clothes on properly. Next is agnosia. Agnosia is loss of sensory ability to recognize objects. So if you're giving a coin to the patient may have difficulty identifying what that is. Ask the patient to close their eyes and ask them to identify what that is. Patient may have difficulty recognizing familiar objects. Next is hyperorality, that is tendency to taste, chew, and put everything in the mouth. And hypermetamorphosis refers to urge to touch everything. And there's another phenomenon that is commonly seen in Alzheimer's is sundowning. That is patient's mood and irritability tend to deteriorate at the later part of the day. Or that means that at night the symptoms are worse, but during the day the patients are complete or are rather okay during the day. So other symptoms are seen are memory impairment. Patient will have difficulty remembering recent events. Gradually it will progress to include both recent and remote memory. And there is a disturbance in executive functioning, that is, there's difficulty in planning, organizing, and for abstract thinking. Next is emotions. So as the illness progresses, the patient will have difficulty showing emotion. There may be a complete absence of emotions. Usually the patient will have a flat facial affect and unresponsiveness with a later stage of Alzheimer's disease. And next is self-assessment. We as a nurse, we need to be aware of our own emotions and inability or difficulties of dealing with a patient with Alzheimer's disease, and we need to share with each other our difficulties and seek help when it's required. So looking again into the symptoms of Alzheimer's disease, there is memory impairment, disturbances of executive functioning, aphasia, I said there's loss of language ability, apraxia, loss of purposeful movement, agnosia, inability to recognize objects. Next is we'll move on to formulating 3 nursing diagnoses for a patient with major neurocognitive disorder. Formulate a teaching plan for a caregiver of a patient with major neurocognitive disorder including interventions for communication, health maintenance, and safe environment. Moving on to diagnostics tests that can be used to identify Alzheimer's disease may include computed tomography scan, positron emission tomography, MMSE, mini mental status examination, a complete physical and neurological examination, a complete medical and historic history, and review of recent symptoms, medication, and nutrition. All these things are required to identify the correct etiology and how much the disease has progressed. A table 23.04 helps us to compare between delirium, dementia, and depression. So as we mentioned in self-assessment, there is a realistic, we need to understand the disease, the progressive nature of the disease. It's a very stressful situation. Use stress management, get support, read on the topic, and realistic outcomes and recognition, and maintaining good self-care yourself. So what are the possible nursing diagnoses for the patient? There's a high risk for wandering, risk for injury, impaired verbal communication, impaired environmental interpretation syndrome, impaired memory, confusion, caregiver role strain, and anticipatory grieving. Next objective is to compose a list of appropriate referrals in the community, including a support group, hotline for information and respite services for persons with dementia and their caregivers. Looking into the nursing interventions, the first approach is person-centered care approach. Even though there is this patient with a cognitive decline, we need to consider that individual and has to develop a relationship with the patient as well as the family members, and need to maintain a respectful relationship with the patient. Next is health teaching and health promotion. Family members need to be educated how to take care of the patient. The table 23.7 in your textbook gives as what are some certain guidelines for self-care in patients with dementia, which includes dressing and bathing, nutrition, bowel and bladder function, and sleep. It's a good reference to look into. Next is referral to community supports. Patient needs to be educated about, or the family members need to be educated about various community supports that are available. Alzheimer's Association is an agency that provides various forms of assistance to individuals. Alzheimer's Association has a community resource finder, which is used to help locate local resources. Your table 23.8 provides the types of services that may be available to patients with dementia. Next is we'll look into the pharmacological interventions. So FDA has approved various medications for the treatment of Alzheimer's disease. Initial, even though they have a marginal improvement in cognition and functioning, the benefits of these medication wane after 1 to 2 years. So patients should weigh the potential side effects against the potential benefits. Few medicines that are used are cholinesterase inhibitors, N-methyl D-aspartate receptor antagonists, and certain medications are used for behavioral symptoms of Alzheimer's disease. The table 2310 in your textbooks gives a list of FDA-approved drugs for Alzheimer's disease, their actions, indications, and side effects. Next, we'll move on to integrative therapy. It says that certain aromatherapy may be useful with patients with dementia to promote relaxation and sleep. Even though there is limited evidence to the effectiveness of aromatherapy, it says that it can provide some sort of relaxation, sleep, and pain relief. The community support may be in the form of transportation services, supervision and care when primary caregivers out of home, referrals to daycare centers, information support groups in the community, meals on wheels, information, respite and residential services, telephone numbers for helplines and home health services. And as a nurse, we need to be aware of what are the community services that are available for the patients in your community that you serve, and the patient and the caregivers need to be educated about the available community supports. So one question is, acute onset of disordered thinking is most associated with delirium, Alzheimer's disease, frontotemporal dementia, and dementia with Lewy bodies. So it's acute onset, so the answer would be delirium. And then before we conclude this chapter, I would want to go over the pharmacological interventions once more. So the pharmacological interventions include 3 major aspects. First is cholinesterase inhibitors. The first medicine, which was marketed in 1993, was Tacrin, but unfortunately it had higher side effects such as elevated liver enzymes, liver transaminase levels was elevated, and liver toxicity was found. So this drug was withdrawn from the market in 2012. The newer drug in the market right now is Donepezil. Its trade name is Aricept. It's a cholinesterase inhibitor, which means that it inhibits the enzyme cholinesterase. So the function of cholinesterase is to break down the acetylcholine in the brain. So cholinesterase inhibitors inhibits this enzyme cholinesterase, so there is no breakdown of acetylcholine. So with Alzheimer's disease, it is found that there is the level of acetylcholine is decreasing. So this drug will prevent that progression of loss of acetylcholine. So Donepezil appears to improve cognitive functions without causing any serious liver toxicity. But some individuals may experience diarrhea or nausea while taking the drug. And usually these are dose related, so the dose may be decreased to help minimize these effects. Another drug, cholinesterase inhibitor, is rivastigmine or Exelon. And another drug is galantamine or Remenil. It is also both prescribed in early stages of dementia. Another drug which we give for Alzheimer's disease is N-methyl D-aspartate receptor antagonist. Example is memantine. The function of it is regulates glutamate activity by blocking the NMDA receptors. So it said that the glutamate excitation may be increased in case of Alzheimer's disease. So this drug reduces that excitatory neurotoxicity caused by glutamate. So it can, it is also added along with the cholinesterase inhibitors, so that there is no neuronal death that is happening. So usually it is indicated in case of moderate to severe dementia. No evidence that it modifies underlying disease, but it's still given. Major side effects are dizziness, agitation, headache, constipation, and confusion. It says that it helps to protect against excessive neuronal stimulation by the glutamate. Another drug which we commonly used in case of Alzheimer's is to control the behavioral symptoms. The few drugs that may be given include antidepressants, antipsychotics, anti-anxiety agents, and anticonvulsants. And most often antipsychotics may be used to control the agitation. But in 2008, it was found that there was a high risk of mortality associated with cardiovascular infectious causes. So as a result, FDA wants that the use of all antipsychotics, both first and second generation, is no longer approved for dementia-related psychosis.